Which is more effective for heart failure, metoprolol or lisinopril? Beta blockers or ACE inhibitors? Let's preface by saying, whenever possible, you really want to utilize both a beta blocker and either an ACE inhibitor, an ARB, or an ARNI, which is an ARB plus a neprilysin inhibitor, because they combat different compensatory mechanisms of heart failure. So when used together, their activity is synergistic and we have a greater impact on survival than if we used just one class alone. We're also learning more about ARNIs, which are neprilysin inhibitors, and we know that they can now be used in place of ACE inhibitors. And so I want to make the distinction that when we talk about life expectancy, right now we don't have data for comparing beta blockers versus ARNIs, like we do beta blockers versus ACEs and our other options. But this is a really practical question because we do have patients that run so hypotensive they can't tolerate both an ACE and a beta blocker. When looking at overall survival and mortality rates, beta blockers will slightly outperform ACE inhibitors or ARBs, meaning their survival rates and overall life expectancy gained from adding a beta blocker in heart failure is likely to be slightly more significant than if we added an ACE inhibitor or an ARB. Keep in mind, target doses are legitimate here. We don't want to start a baby dose and then leave it alone. We want a target dose. We titrate up to that target dose, or at least titrate to the maximum tolerated beta blocker dose. This is where we really see the best morbidity and mortality benefit. So let's say we have a 70-year-old male with class 3 heart failure. For every additional year of life expectancy added by an ACE inhibitor or an aldosterone antagonist, a beta blocker might add a year and a half. Now, add that full standard of care. We're talking ACE or ARB or ARNI, a beta blocker, aldosterone antagonist like spironolactone, a statin, and hitting those target doses, and now you have compounded the effect, which may increase life expectancy by 5 or 10 years. These aren't exact numbers. This is an example to compare the magnitude of effect from one class to the other, and it's critical to understand that we must have practitioners on your team to evaluate medication therapy, evaluate adherence in every single heart failure patient. That's the Reinhartz Rundown. Make sure you visit mobilehealthconsultants.com and subscribe to get our next video.